All right, can everybody see that okay?
Yes, ma'am.
All right. Well, thanks for having me today. This is actually kind of a part two of a presentation that I think I gave last year. We were talking about assessments of aggression and kind of treatment of acute emergency aggression, and we reviewed the beta study. And this is kind of continuation of the treatment needs of conditions that might present with chronic aggression and sort of the treatment approach to that. So. Without further ado, we'll go ahead and get started. We're going to again talk about and review a little bit about the importance of how you assess aggressive behavior, understanding the etiology and the purpose of the behavior, and trying to help sort of distinguish maybe some of the traits, which we're going to define as callous unemotional traits that might be part of how it affects the outcomes of certain types of disorders around, especially disorders of disruptive behavior, and really talk about both therapeutic treatment approaches and how to construct a approach about medications. So we will do all these things in the next hour. As always, I love questions. Please come off mute, interrupt me, drop it in the chat. I can see the chat, so you can drop the questions right alongside the chat as we go. I'd love to answer them in the moment. But one of the most important places to start is that aggression means a lot of different things to different people. And especially as we're communicating about aggression, it's important to really understand the different types of aggression, the severity of the aggression, to really describe the aggression. Um, I do a lot of chart reviews and review clinical information, and the term aggression itself is really actually not very helpful. It doesn't tell you much about the problem, the severity of the problem, and it really doesn't give justice to a condition that's terrifying and scary and a significant problem, especially in kids, but also to understand the wide range of what it accomplishes. I always encourage people to describe the behavior and what happened, not just use that word. It's important to talk about how aggression is characterized. We have verbal aggression, like verbal threats. We have physical aggression that can be directed toward self or to others, and we have property destruction. And sometimes just describing what occurred instead of using a generic term like they were aggression or even made a verbal aggressive statement, just describing the behavior can often tell the story more. And it's actually really important sometimes when you feel stuck at understanding the etiology to get that level of detail. And also that word means lots of different things to lots of people. So as much description as we can describe and link really does help to try to understand and treat the behavior. The severity of the aggression matters too. And when you're taking a history of a child that has had significant aggressive behaviors, it's helpful again to kind of gauge the severity. So here again, some questions. Were there some triggers? Did this appear to be aggression that was premeditated or planned or had a trigger or not? Was there use of a weapon? Were they carrying a weapon? Was there a threat of a weapon? Did they have access to a weapon? Did they make attempts to gain access to a weapon before the event? What happened following the event? Did someone need hospitalized? Did someone seek medical treatment? If property was damaged, how much? Was it one item? Was it a pencil? Was it $5,000 worth of damage? These levels of things do matter. How many people were victimized in the approach? And then, sometimes when you're interviewing someone, you need to take a history of how often this occurs. Was this a high intensity event that had lots and lots of safety issues, but only happened once in a year? Or are there lots of small events that occur multiple times a week? So you really need to know how often it happens, how severe it is, and sometimes in your question asking when's the last time the aggressive event happened and describing that. And then I like to even ask sometimes, what's the most aggressive thing or most dangerous thing that's ever occurred? Again, to provide some context on risk and severity. But these things also really matter in terms of assessing the function and how big of a problem this becomes. And many of you who have ever heard me talk have probably seen this slide 1,000 times. But when you're talking about behaviors, you cannot treat a behavior without understanding the behavior or the purpose of the behavior. And this ABC sort of approach is really a big part of that assessment. So the antecedents are the things that happened before the behaviors. What occurred, what conversations occurred, what were the environmental factors, were there cues, were there triggers? Did somebody say something to the child? Was the child threatened? Sometimes there's also a underlying medical condition, or in this case, a psychiatric condition that remains untreated. Was the patient depressed? Was the patient psychotic? Was there untreated ADHD that could have led up to this? As a general rule, when we move to treatment and we're talking about antecedents, it's usually medications, target antecedents, things that were treatable or were modifiable factors from a med treatment perspective. But not all behaviors have clear causes. Sometimes the behavior is for a purpose. And sometimes the behavior achieves more, matters more in what came after the behavior. I've given this example before too, but I took my very hungry daughter to the grocery store after work, thinking I was going to get through the checkout line and get home and make a fabulous dinner. And she wanted a candy bar. And so she totally had a meltdown in the line because she wanted that candy bar and she cried and she threw things, and I gave her the candy bar. She stopped. What did I do? I actually taught her how to get a candy bar from me that day, that crying and screaming achieved a purpose to get a candy bar. And man, did I have to undo that so it never happened again. But at that point, the trigger was hunger, but it was actually my behavior as a parent giving her the candy bar that may have reinforced the behavior because that behavior had a purpose. And I gave in to the purpose that day of that specific disruptive behavior. So sometimes it's what the behavior achieves. And we may see this a lot. Sometimes kids hit people to be removed from a situation, and the goal was to leave. And they knew if they hit someone, they would get removed. I had a patient once who went to the school counselor and said, "I want to please call my mom. I don't feel good. I want to leave." The kid really wanted to leave school. This had been a problem, and the counselor didn't want to call his mom because she really didn't think he was sick. But the kid then went out and punched somebody, and then they called his mom and took him away from school. Again, not ideal, but that behavior had a purpose. And the kid knew if he hit somebody, he would go home. And we reinforced the hitting by giving him what he wanted. Then the fact that the call would have also served to have called his mom and maybe have not gotten a safety consequence. So it's important when we look at behaviors again to look at the whole purpose, because if we do not understand the antecedents and the consequences when we're talking about things like aggression, we will have no idea how to treat it. And while meds may help antecedents, medication does not help consequences. Medication does not help the purposeful behaviors. And so this is really where we talk about therapy and therapeutic interventions to address those. And for most kids with aggression, they often need both, perhaps, especially for any comorbidities or antecedents. And so, as with many things, often the combination of treatments usually is a critical piece, especially with kids and families, where often family work is just as critical as the kid only work. So as we will talk about today, lots of treatment plans involve multiple modalities and targets to really have great success. So before we jump into the actual piece next, I just really want to make sure this slide is embedded in everybody's brain for eternity, because this is truly the most critical piece to truly understand those behaviors before we can treat it. So is there any questions about this? I know some of you have heard me talk about this before. Okay. So at the end of the day, aggression or agitation is really a symptom. It is not a diagnosis that we can treat in its own right. And this is just to remind you that aggression is present in many, many conditions. And these are not all psychiatric conditions. This can also be present in medical conditions or delirium. So aggression is a symptom, and we must be a detective of that symptom. as we move forward to this lecture is going to really focus on what we call disruptive behavior disorders, which are the oppositional defiant disorder and conduct disorder that I'm going to refer to, of which aggression may be a part of a presentation of those conditions. So we're going to dial in treatment specifically focused on these disorders. But again, there are many, many things that can cause aggression. I will also tell you as a clinician, I also think it's a fallacy that I often see where anytime a kid is aggressive, they immediately get an ODD or conduct disorder diagnosis. And we're going to talk about that because that's not exactly true. If you are aggressive, that does not mean you have ODD or conduct disorder, but all too often, that's the immediate diagnosis that people go to. And it's much more complicated than that. I will tell you, as a child and adolescent psychiatrist, I usually take away the diagnosis because I find a better explanation for the behavior. And that's one of the most important parts about this next step is their diagnosis of exclusions. You give the diagnosis in absence of another explanation for the behaviors. And we'll talk more about that, but it's really important that we do that. And in fact, when I see kids only with ODD and conduct disorder as their diagnoses, it's rarely that simple. And comorbidity is more the rules. So again, we'll talk a little bit about why that happens, but it's really important that again we look at this very holistically because the treatment of ODD and conduct disorder is quite different if you have another cause in terms of success and also that as an aside too, if you treat something else and the oppositional behavior goes away, you should remove the diagnosis. It is very likely that was not accurate anyway, that you treated the other piece and it went away. Oh. So these are just very brief definitions from the DSM about what conduct disorder and oppositional defiant disorder means. Conduct disorder is kind of viewed as the more extreme form of disruptive behaviors, and it includes having 3 of 15 symptoms in the context of a 12-month period, including one symptom in the last 6 months. This is incredibly important to realize the time frame because I'm sure, as Dr. Lillard would tell you, we have kids that might have conduct disordered behaviors that occurred 5 years ago. They literally have done nothing for 5 years and they still may have that diagnosis following them forever. And they truly do have a time cap on them. So it is important to understand that as well. But these are very serious behaviors that, again, one of the symptoms is truly aggression toward people or animals. This is purposely bullying, purposely intimidating, often using weapons to threaten people to manipulate and get what you want. True physical cruelty, forced sexualized behaviors, purposeful destruction of property, more on the true vandalism, arson side of things, not inadvertent destruction of property that happened accidentally in the midst of a tantrum. These are again, very different behaviors. This is true deceitfulness. This is lying, conning, breaking into homes. And then a true violation of the rules, again, where the purpose is the violation of the rules. And that's things like running away and truancy. And I highlight those things because if you're doing a differential of these behaviors, these are these are all behaviors that sound very criminal and very much kind of getting into that criminalized behavior line. The challenge with that is I could take any symptom from this list and again do a differential and give you many other reasons for the behaviors. So we need to truly again go back to it. If I told you the child was getting picked on and bullied at school and that's why they weren't going, that changes the time frame of what truancy actually may mean. If a child is running away from home because their abuser is at home and they are afraid they're going to get beaten, running away again has a different context and purposely running away to be out of supervision or to do what you want. And so again, that ABC understanding of that behavior is really critical. But conduct disorder, these are very serious behaviors that jeopardize the safety of the community and are very purposely designed to fit that. In fact, in the the construct of conduct disorder, some of these will clearly move to antisocial personality disorder, which we're going to talk about here in a minute, and then likely criminal behavior. That's the conduct disorder is the one that really does carry that risk for being in jail. Oppositional defiant disorder is also sometimes viewed in this category of disruptive behavior disorders, but as a qualifier, opposition defiant disorder is probably one of the truly, I think, most understood diagnosis in the scope of this. And a large majority of oppositional defiant disorder never moves to conduct disorder. That's usually around 30 to 40% at best. And it's a host of symptoms that again has a lot of overlapping qualities to it. But it is a presentation of 4 symptoms within 6 months, of which includes some mood symptoms, which you'll see are not included in conduct disorder. That there's this irritableness, angry, easily annoyed, touchy, resentful kind of behavior. And honestly, this symptom category overlaps with a lot of things you might see in anxiety disorders and depression. And so it's really important you rule those things out, because if you truly are depressed or anxious, you really probably shouldn't be giving an ODD diagnosis if that better explains those symptoms, because there is just a ton of overlap there. Again, the next category, argumentative and defiant, arguing with adults, actively defying requests, deliberately annoying others, blaming others for their mistakes, and then vindictiveness or spiteful behavior in the last 6 months. And I want you to think about those symptoms, because we're going to talk about kind of what those symptoms may mean. And I think one of the challenges with ODD is these are symptoms often in the eye of the beholder or the reporter that can really influence how we get information. And sometimes the way one adult experiences behavior could be quite different than the way another adult experiences behaviors. In fact, in certain circles, like the legal world, we celebrate kids that can argue and articulate and problem solve. Maybe defying a request is, if it's a really bad request, maybe refusing to do something you know is wrong is not a bad thing. So again, these are really highly dependent on the observers sometimes, and feelings of the adults sometimes in the kid's life. And it's a little bit harder to subjectify. So I'm sorry, it's very subjective. It's very hard to maybe objectify it sometimes, terms like spitefulness or vindictiveness, but these are the official criteria. And then, of course, when we talk about aggression and disruptive behaviors, and I know many of you have probably heard this too. I've legitimately had parents that at the end of the day say, "I'm just really worried my kid's gonna hurt somebody and go to jail," and that is truly a deep-seated fear. And as I said, this is a pathway, especially conduct disorder is a pathway for the development of some very severe pathology that would link to that, and that's antisocial personality disorder. Is a personality disorder diagnosis, which means you cannot have this diagnosis until you're 18. But when we're talking about kids, this is often the fear that caregivers have, that something could progress to that. And this, again, is linked to conduct disorder because it actually requires the presence of conduct disorder by age 15, so that there's evidence that these behaviors have existed for some time deep into childhood. And you'll see an extension of those very purposeful, criminal-like behaviors. Colleen?
Can I clarify something? Because
Yep,
I sometimes see this. My understanding is that you have to have evidence of a conduct disorder before age 15, not that they
correct.
meet full criteria. So sometimes people think, oh, they didn't meet full criteria for conduct disorder, so I can't give this. Not that I want more antisocial
Yeah,
personality disorder given.
correct. And they may never have been assessed, right? So it's also
Right.
that it's not that it has to be formalized. It just has to show that the pattern of the behavior
Yes.
started before 15. Yes. But again, it's the same kind of extension. Clear failure to conform to laws that are maintaining safety in society, things that are behaviors that would get you arrested, deceitfulness, conning people, trying to obtain pleasure or profit from the lies and the conduct. They may be called manipulative or charming, impulsive, You again see some irritability and aggressiveness that overlaps a little with the ODD piece, but this is the continued physical assaulting aggressive behaviors. Again, usually with purposefulness to intimidate or to obtain what they want through evoking fear, disregard for safety, being irresponsible, and then ultimately lacking remorse, and not really seeing their behaviors as a problem. To others because again they can often be viewed as sort of self-centered and self-focused with those intent. So this is what everybody fears. The good news is most childhood disruptive behaviors does not lead to this at all, and so I think this is more the exception than the rule, but I think it is often at the forefront of worry when a child's exhibiting aggressive behavior. It certainly gets Colleen a lot of referrals and risk assessments, I think often because people are truly worried about these things. So
Can I
when we
mention one more thing
yeah, go for it.
that goes with antisocial because I feel like this often is asked. So when you hear the term psychopathy or a psychopath, think of those as a subset of people who have antisocial personality disorder, but they're a like much more severe set of individuals. So all psychopaths likely have antisocial personality disorder, but not all people with antisocial personality disorder are actually psychopaths.
There's always a spectrum. And again, when we talk about aggression, there's this, again, kind of different grouping of aggression that often links to some of the biology and sort of understanding of the etiology of it, even sort of neurologically. So I don't know if you've ever heard of these terms before, but there's sometimes a split in the description of aggression from this cold aggression to hot aggression. So cold aggression is kind of a very secretive, pre-planned, premeditated, sort of a very purposeful aggression, really designed to have a purpose or achieve a goal. The reason it's called cold is because there's often a disconnect of reactivity emotionally with this aggression. And that actually has been linked to a lot of biological things where some of the explosive emotionality around the amygdala, monoamine oxidase, and some of the neurotransmitters, actually the brain show a reduction of that emotional discharge. And so it is linked to some findings where they just don't react as much in their brains emotionally to situations that might evoke fear or emotion in other people. And so that again, very covert, proactive, cold aggression is often what again goes to that more antisocial conduct disorder quality. As an alternative, we have hot aggression, which is more of a very reactive sort of response that comes with that emotional discharge. It's often usually accompanied by anger or fear or frustration or a threat. And you will hear people just that's more of that irritable, on edge, anger sort of thing, like a temper flare or just I did it. And I sometimes I think when people respond this way, they often say, I don't know why, I just felt really angry. Or I sometimes I can't remember. I just remember being like really overwhelmed and kind of doing things. And often after hot aggression, there's almost a sense of feeling better. Not so much that they feel better that they hurt someone or did something, but it's almost like that physical connection of hitting something or was a release from the emotional distress. And again, you can sort of tease that out, and there's often more maybe remorse about the behaviors again because it's connected to feeling out of control or emotional that people will describe with it. Equal damage may occur from the behavior, but there's often a different etiology or experience people have when they talk about those symptoms. We're going to come back to this in a minute, but I do think it is helpful to think that way. And then when you scan the brains or look at neurotransmitters, people are having more emotional responses clearly, and their brains are kind of lighting up more in the amygdala. They are having like more evidence of emotional reactivity than when cold aggression occurs. So a predictor, and this is sort of a newer term in child and adolescent psychiatry, I think, over the last decade or so, but when people look at aggression or events, there's kind of this desire, well, let's predict the ones that are more at risk of moving toward antisocial, or not. And so these terms or these traits are sort of defined as callous or unemotional traits that are, again, those cold traits that have really been kind of picked out of this. And so those traits would be a lack of remorse or guilt. They just didn't feel bad that they did it. In fact, sometimes they may be glad they did it, even after the event when everyone is upset with them. That there's a lack of empathy, that they seem to not care or really understand the feelings of others. That's the callousness piece. That there's generally kind of uncaring behaviors. They're not really concerned about how they're viewed in school or performing. And there's a defiance or an active resistance that comes with an even more intense rage or anger at being forced to do something that falls in this category. And again, while these may be linked to antisocial behaviors, I'll also tell you all of these can be in the eye of the beholder a little bit and have multiple differentials. Challenges with empathy are seen in autism. Not caring about things can be a symptom of depression, right? So there's lots and lots of overlap. So again, it's really important we don't take any one of these without the evaluation piece. But these are some of the, again, qualifiers to outcomes. But again, it really requires a really in-depth assessment. And also, again, it's really important we interview the kid alongside various adults because some of these symptoms can be the impression. And I know it's never that simple, but there are lots of times where you will hear someone say they have absolutely no empathy. I know they don't care about me. I've never experienced that. And then another parent or another caregiver says the absolute worst. I know they have empathy. I've seen it in this section. So a lot of these relational constructs can again be in the eye of the beholder. And so again, as many people as you can interview in a child's life, there's many sources of collateral you can get. You can get very different stories about that. And of course, the kids that display the behaviors in multiple environments are also at higher risk of those being more pervasive and concerning. And so, as I mentioned, these traits have become kind of a focus of this because they often predict outcome. And we're going to talk about some of those outcomes, but some of these callous and unemotional traits are actually what predict true violence, true aggression, and that term I can never say it, psychopathy that people are really afraid of when they talk about this. It also seems that we, and again, that neurologic reactivity, that cold aggression is actually a little bit more heritable than the hot kind. And so you can sometimes see more genetic patterns occurring with those types of things as well. And we're going to come back to this when we look at some treatment modalities to understand this, because at the end of the day, there's a question about, well, we can treat disruptive behaviors. Can we change the presentation of the callous emotional traits? Do those receive treatment? Those as well. I'm going to talk about that a little bit. And so again, just some pitfalls about these diagnoses. I just really want to highlight because again, it is my experience that they get slapped on a lot of kids without a good assessment. And it's important to understand the biases and pitfalls you may have in giving these. One, sometimes people give labels to things that are truly normal. And it's really important to understand the normal expectations of development. And just some examples here. I mean, I've seen a 4-year-old diagnosed with ODD. I mean, and you're not supposed to do that, really. I mean, and it was, well, they don't listen to me. They like the word no. Well, all 4-year-olds like the word, don't like the word no. Like that's normal. And so it's again, it may seem unusual to this group, but it does happen because people forget the developmental pathway. And also if someone has intellectual disabilities, you have to correct for their correct cognitive age to understand how they might be responding. And so that's a really critical piece to think about these developmentally. An adolescent wanting to explore some individuation or to kind of break out of maybe some normative family behaviors to explore other things that maybe goes against their family's cultural values could really be viewed as defiance or aggression or violating of serious rules, when in fact it may be again just part of that developmental thing. And again, these are all great, you have to understand the spectrum and severity of these things, but it's really important that we don't just label things from the family or the parent perspective either. Many of these symptoms overlap with every other diagnosis on the planet in mental health. So sometimes I think it's more important that you rule out things like ADHD, anxiety, trauma. You would not imagine how many kids with cognitive disorder and ODD I've seen that actually have severe reactive trauma and no one gave them a trauma disorder diagnosis. And when you look at it from that lens, all their behaviors make a whole lot more sense than viewing it as criminal and it's very shocking sometimes, especially maybe dependent on where kids enter the system. If they show up in a psychiatrist's office as an outpatient with their family, are they more likely to be looked at for anxiety, depression? If they show up because they got picked up by the police, and from the court of law, are we viewing it more with the lens of the law? And this is also that part that the perception of these behaviors really matter. Adults' legal systems are more likely to be looking for more legal-like behaviors in their presentation. But as I said many times, if you treat the other things going on, oftentimes the disruptive behaviors go away. And that's also important to note. And then we have kids that only have certain behaviors in certain places. This child only has this behavior with this adult. No one else sees it. That doesn't mean it doesn't exist or there's not a problem that needs addressed, but it also, again, changes the narrative a little bit and how you diagnose these things. So again, always be mindful of that full assessment. So, of course, none of us exist in a vacuum, and children in particular do not exist in a vacuum. And so often the environment they have with family or school can really be a big piece of the progression of this. And so this is a term often linked to disruptive behaviors, and it's something I want to go through a little bit because it really kind of helps target why we do the therapeutic interventions. So this coercive family dynamic is used to sort of explain the purpose of the behavior and the mutual patterns that continue sometimes in relationships and families that may make those difficult behaviors continue to get worse. And often what we end up targeting when we're trying to break a behavioral cycle. So, let's go back to my example with the candy bar. And that was one example. I did not do it again. But let's say that became a pattern. Let's say every time my child wanted something, they threatened to have a tantrum, to kick me, to cry very purposefully. They got louder, louder. I got embarrassed. I wanted it to stop. I gave them another candy bar. The kid stops. I feel better. I sort of felt like I won. The kid feels like they won. Everyone feels slightly happy. Maybe I'm still a little embarrassed, but it ceased. Then the next craving comes, the next urge, the next time they want something I want to get in, they get louder. They do it bigger. They make a bigger threat, a bigger scene to get me to give in, and I do. And that's often the pattern that relationships take with this when behavior has purpose, because you are achieving something to get what you want. And that's that negative reinforcement cycle that often is a very large part of what continues some of these behaviors. And many times, some of the behaviors we're talking about have been inadvertently reinforced over and over again by schools and systems. I had a kid who I had a kid who hated going to school. Um, was definitely a truancy risk, probably from significant anxiety, but really learned how to get sent home. And it became almost like a game. I know everybody wanted him to go to school, but he started learning, they just kept sending home over and over again. He would have to do something, get sent home. The next time what he did before wasn't quite enough, so he did a little more to get sent home. And became a very, very difficult cycle to break because the desire to go home and be sent home was so strong. We were reinforcing that because it was getting to those levels. So this process is really what often needs kind of an intervention, sometimes with patterns of behaviors that have occurred. And I know the positive behavioral support staff on this totally see this, and many times that's one of the interventions that we're looking at. So when we think about therapeutic interventions, we're talking about different targets for therapy. You have true parent-focused interventions, you have true child-focused interventions, you might have family-focused interventions, and then there's been a term called multi-systemic therapy, which is very specific to very high-risk youth that's designed to kind of provide intensive 24-hour response at the systems level that has been used in some states, usually in line with juvenile justice as an approach. We currently do not have any MST options in West Virginia, but it is a form of treatment that has had some evidence when we really get to that juvenile justice legal severe risk to the population risk. So parent-focused treatments are really, again, designed as the target is the parent, where we really spend a lot of time helping the parent become the teacher at truly what they want to see and become very aware of what they reinforce. And at the end of the day, we really want people to reinforce the things they want to see. Let's reinforce the positive behaviors. Reward them. Don't inadvertently give in and reinforce those negative things. And you literally teach about purposes of behaviors and kind of what you're trying to do and see that you are part of this cycle and help ways to break it. And this is not easy. We talked about this, Kelly. I mean, being a parent is really hard. Being a caregiver is probably the hardest job. And to undo what is sometimes a very natural response is nothing easy about it. But sometimes the response is instead of just reacting and getting louder and controlling your own emotional response, you have to become a broken record. You have to look calm. You have to be immediate in your responses and directive in your responses. And you have to be incredibly predictable. To intentionally break a cycle, you may have to overly be routine and predictable and do very hard things when you're screaming inside so that you don't give in. Because you know if you gave in, the behavior would immediately cease, but you know that it will come back. And so you have to get through the extinction burst sometimes. And those are strategies like helping parents pick their battles, creating a hierarchy of what's important, what's okay to let go, kind of focusing in on key things. Using broken record techniques where you say the same thing over and over again so that you're showing your consistency. You really have to help parents not have an emotional response and have more of a logical one because emotions are often running very high. And you have to help people learn to say no in a way that occurs early on and not in the heat of the moment sometimes, and really have predictable boundaries and responses. The other part of that is really learning how to shift out of crisis mode and negatives into really looking for the positives, because it's where you look for the positives that you really teach kids and reward them for the behaviors you want to see. And that's hard sometimes. All of us think people should just do what they do and we should, but it doesn't work like that. Even as adults, we like to hear what we're doing well, and sometimes we have to really label it. This is often where things like PCIT and some of those pride skills that you've heard about really matter. Like kids need praise for the things you want to see. You have to reflect and listen and teach them how to show respect. Teach them how to listen. Teach them how to have those more normal interactions by modeling it yourself, even when it's really hard. And And if we look at outcomes, some of the best outcomes we're going to see with those callous emotional traits are the ones taught in these parent-focused interventions. So it is really critical to teach emotional empathy by modeling. And that's often really the only part of treatment for this that really truly shows reduction in those callous emotional traits. I gave that away, but that's really key. This is the most important piece at the psychopathy risk in terms of the parent part. Child-focused treatments also do help the child maybe again connect their thoughts and feelings to their behaviors through CBT techniques. We talk about problem solving strategies like, well, how do you handle it when you're angry? Like, what are other things you can do that are safe or won't get you in trouble? We help kids learn how to listen. We help kids learn how to communicate and to communicate more effectively. You know, often there's a lot of not feeling heard in here. So how can you make a request without violating the rights of others? How can you ask for things? I statements, how to be consistent, how to be courteous. Let's teach how to politely ask something so you don't get a reaction. How do we improve your social skills or your communication skills so that when you want something or you can be more effective in your interactions on the playground or with your friends. So social skills training could also go a long way, especially to help interpersonal problems. Family-focused treatment is often looking at the family with joint goals to maybe work on something that benefits everyone. Again, a little different focus. This is often where functional family therapy plays a role. At what are things we can do that help the family as a unit instead of one individual person in the family is sort of also a big focus on building interpersonal relationships within the family and communication in the family. And then MST is really this very small, intensive response team that is assigned to a child and goes everywhere the child goes when they have problems. So if there's a crisis at school or home, even in the middle of the night, the same team, the same techniques, the same consistency go and respond to it. Because a lot of these problems exist in the system when one system responds differently than another system. For example, sometimes certain behaviors may be rewarded at home, but not rewarded in the school, or vice versa. And so these teams are designed to implement the same consistency and reward response expectations across all communities. And then like when you look at this and depending, and this is going back to a very large study that was done on over 9,000 participants, what truly works? Well, these treatments really do work. They do, regardless of whether you have callous emotional traits or not, everybody got better to some degree. And they had similar reductions in their improvement. The challenge was those that had the callous unemotional traits started higher in their symptom burden. So even though they reduced about the same, they probably still ended up a little less functional than those. But they did have similar reductions. The behavior planning did not truly seem to help the callous unemotional traits, specifically regarding family work and individual work. In fact, it was really only the parent-focused treatments that really helped those callous unemotional traits when they broke down the different interventions. And so I've said this so many times, but it's very hard to work with kids if you don't also work with the parents because they're the ones that have to extend the modeling every day to really get it to stick. And this really again proves if you're really trying to show empathy, if you're really trying to show respect and care toward others, it has to be modeled for the child. And this was the one intervention that really seemed to help in the callous unemotional trait risk at reducing antisocial personality. The other piece, and I'm totally gonna run out of time, as usual, but is you gotta beware the reason for the change. And this is something I, when you get better, you get better. When you have less disruptive behaviors, you have less disruptive behaviors. It's a win. Let's not get stuck too much on the why, because one of the things I think that the why creates is what was the reason for the change. And there are times when I think parents get really frustrated. Well, they're doing better, but I want them to want to do better, or I want them to know how hard it was. They want them to feel sorry. Those are kind of things that are really not helpful to success, to get stuck on the reason. And success often begets success, and those things may come way later than the actual improvement. And kids may not be able to feel those things until much further down at another developmental stage when they can see that. So it's important we accept success as success and not get stuck on why it was successful or that they were sorry they messed up. That's really important to celebrate. And then I do have many, many slides about medicines, and I wonder if I should just make the medicine slides my next lecture because I signed up for some. But since many of you joined, I'm going to start with there's actually no clear medicines for these things. And as a teaser, since I will do the rest of this next time, I was going to ask the group, as a general rule, do you think medicines are best at targeting cold aggression or hot aggression? What would you say? Any votes?
I vote for hot.
Hot? I got a hot vote. Any other votes? Hot? I got two hots. I got a cold.
I'm gonna say cold.
Got another cold. It's tied. All right, I'll take the tie. The answer is hot. Hot aggression is more likely to respond to medicines. And I'm gonna just leave that as the teaser. So, Kelly, I think I just signed up for a couple dates, but we can make my first one the medicines for aggression. And the other little teaser is there's no medication specifically for aggression. So when we talk about meds, we make it really messy and we have to come up with a true approach to how we do this. So I could probably talk for an hour on that. So we're going to leave that end for a teaser because I really ran out of time. Does anybody have any questions? I'll also say it is very hard for the medicines to work without the therapy is the other most important piece. And so as we talk about meds the next time I talk, it's always important to add the therapy. The therapy does not teach the skills. The meds do not teach the skills. The meds do not teach empathy. Meds alone have no clear risk reduction for psychopathy or do not predict your legal involvement. They're very much adjunctive to the tasks of treating other things and to establish safety so that you can do therapy is really what we're going to focus on. But there's a whole approach to that I want to give way more time for because I clearly talk too much. So thank you all. Any questions I can answer?